Okay, so on each side, we're going to twist to the right. Well, that's a good start. Let's see if we can get a normal. Okay, you see here, when she goes to the left, rotates left, there's this obvious left side bending curve, but at the thoracolumbar junction, it changes, it reverses and straightens out. You don't always see an actual curve, but it's a change in the curve that's important. Okay, turn 90 degrees. Good. Here, it never changes. And look at how much rotation she's lost. That's a straight curve, C curve, all the way down to S1. So my first question, turn face the board again. My first question is it that it can't left side bend? Oh, sorry, is it that it can't right side bend? Because the lumbar spine can't right side bend. So that's easy to check, yes? Over to the right. And she can side bend to the right, so it's not the lumbar spine. So the next thing is, maybe it's T10, 11, 11, 12, because if they can't rotate, then there's not enough torsion to generate the reversal of the curve. So let's get you up onto your right side.
Facing them?
Yeah. No. I'm going into left rotation, right? So you'll be facing me. So I'm going to simply rotate her down, no side bending, just rotate her in neutral. So neutral rotation, arm is at 40 degrees. Twist. Good. So that'll be the position I start her in. Now you can reverse. The key to this region is that the ribs do not attach in the front. The 11th and 12th ribs are floating ribs, and they merely are mobile muscle attachments. Since the ribs do not attach to the rib cage, then there is no restriction potentially to the amount of rotation. So the disc and the facets will stop it, but at the moment we can actually produce pure rotation, a significant amount of rotation. And as soon as you hit L1, T12 L1, bang, the rotation is very, very limited. It's night and day. If I find that restriction, then I'll manipulate it, straighten that leg. Simplest manipulation, neutral locking, for those who've done the level 4, neutral neutral from above, neutral neutral from below, and then no need to even worry about the side bending. Good. Stand up for me. So we've done that. Okay, so which way do we have you stand? Yeah. Twist to the left. Okay. And to the right. To the left. Still not reversing. So there's only one thing left now. The lumbar spine's good, the thoracolumbar joints are good. If she's not reversing, it means psoas is imbalanced. And if she can't rotate left and reverse the curve into right side bending, either the left psoas is too tight, too facilitated, or the right side is too inhibited. With me on that one? Maybe?
Say it one more time.
Okay. we've cleared the joints. All the joints are functioning, and therefore she should be able to reverse her curve. If she can't, it means it's psoas, and that was the importance of understanding psoas is what reverses the curve. So, because she can't side bend right with left rotation, it means the right psoas is either too weak and inhibited to produce it, or the left is too tight to allow it, or in most cases both. Up on here.
Right side.
You go, Chef. So this is not a psoas stretch, it's a psoas balancing act. We're going to inhibit the right side and facilitate the left side. Okay. So the first thing I'm going to do is to take up the left rotation. The thorax has no choice but to side bend left. So at the moment her lumbar spine is rotated into neutral, but the thoracic spine is side bent left. Straighten this leg. Relax. Now, using this side of her pelvis, I produce side bending to the right. And now I'm going to say, don't let me pull your left shoulder forwards. Don't let me lift your left hip. So simultaneously she's resisting left rotation, or resisting into left rotation and right side bending. Relax. There are only two muscles that can perform that combination, and that is psoas and the external obliques. So I take up the slack. Hold again. Hold. And relax. Hold. Hold. And let go. And I'll just keep doing that until there's no more slack. Stand up for me. Rotate to the right, sorry, to the left. Okay, so it's straightening out. We've got a lot more rotation, but she's still going to need to stretch this on a regular basis. So here's her home exercise. Twist, and then side bend right. Twist to the left. Follow the plane of your shoulders to the right. Twice every hour. Okay, so here's the screen without any positive. Lumbar spine. Side bend right. Side bend left. Good, hand up. Lean backwards. Side bend right. Side bend left. Good. Clear. This lumbar spine dealt with. Rotate right. Looking for the curve. Rotate left. Good. If you find a positive, you have to come out of the circle, fix it. Otherwise, the other tests are also going to be affected. That's thoracolumbar. Up on here for me.
Earl, the standing side bending in a psoas imbalance would not be affected then? Because why?
If the psoas was tight on one side, would it affect side bending? No, and I think it's just because it's a different movement.
Okay.
What we're doing when we're doing this is rotation, which is really stresses the psoas muscls,
Okay.
whereas this is probably more likely the abdominals and quadratus lumborum controlling that, erector spinae. I think if I was looking at that, the psoas is too close to the axis of side bending to actually affect it, but have a major impact on rotation. Good, on your back.
Head there.
Don't worry. How many people have not seen this tracking test? Okay. This was developed by Gail Malloy on her work on athletes in the Olympic Training Center in Colorado Springs. She was concerned that many of these young women were developing hip, groin, knee and foot pain without any suggestion as to why, no history of trauma. So she decided she'd check everything, every joint, and came up with this. What we've got to do is, don't help me, going to take the hip up into, so this is just steadying, it's not pushing, and moving her knee up towards her clavicle. So we get full rotation, no tracking off to the side. This position, good internal rotation, which means the external rotators are not overly tight. Hold, don't let me pull. And good strength of the external rotators in their inner range. Have you got a hip problem?
Yeah.
Flip
Yes.
around.
This is the hip that got hit. I had 35 miles an hour by the car.
Which one?
Right one.
Okay. You shouldn't go playing with cars. I've told you before.
I'm trying to learn.
Steel and flesh do not mix together. So here this is quite different. As I approach 30, as I approach 90 degrees, God, I wish I was approaching 30. There's a distinct loss of the tracking going towards her clavicle, and her hip goes into abduction and external rotation. At 90 degrees, if I test the rotation, there's obvious gross restriction. Keep your foot away from me. Hold. Come on, you cyclist. Hold. No. So very, very weak in external rotators in their inner range. If I tested her in the outer range, they'd be strong, which automatically tells me that this is a recruitment problem, not weakness of the muscle per se. Flip over, face that way. The treatment is a manipulation, also designed by Gail. And because of that weakness, when she stands up, the external rotators, being weak, will allow her hip to internally rotate. Weakness in the external rotators creates a reflex weakness in pes anserinus and tib post. Combination of those three muscles ensures that the leg will habitually be internally rotated when standing. So the first thing it takes to hit, patellar tracking. Patellar maltracking is, as one of my colleagues put it, as common as spots in young girls, because the weakness in the imbalance in the hip is very much a female problem, which is what Gail picked up. Infrapatellar tendinitis or tendinosis, the medial collateral knee strain, medial coronary ligament strain, whole list of things. In the foot because the hip is internally rotated, tend to take weight on the medial tubercle. The medial tubercle of the heel is never designed to take weight, ever. So you start taking weight on it, we start to get microfractures. We get what's called a periostitis, or if it comes from a doctor, it'll be plantar fasciitis. Interesting reading that article on Dunning's criticism of that paper on needling for plantar fasciitis. And I'm thinking to myself, wow, will they ever understand that plantar fasciitis only exists in diseases? You get a true plantar fasciitis, you've probably got Reiter's syndrome, ankylosing spondylitis, infective colitis. These are all causes of plantar fasciitis, but usually it affects all 4 limbs. So, how to correct this? Because it's going to cause a lot of mischief in our young athletes. Well, listen, the theory here is that we've got an overzealous zoas. Oh, that's a thing and a half. And it's pulling the head of the femur upwards and forwards against the labrum. It wears on the labrum from the inside. And the labrum very slightly detaches, but it's enough to make the hip now unstable. So the hip is constantly pulled forwards and starts to operate in a different neutral. What I'm going to do is clip this so it spins the femur and drives the head of the femur backwards. And there's some people you love doing that to more than others. It doesn't matter how much you explain that to the patient. You can say whatever you want. I'm about to whack you up the bum, they clip your hip, right? And they go, oh, yeah, okay, okay. When you do it, it's a shock. And one patient, I did that, she suddenly looked at me like this and went, feeling any better now? So I simply said, no, got to do it again. Just to be sure. But afterwards, when you show them what's happening, they are astonished. Tracking normal, range of motion normal, hold, strength normal. Instantly. Of course, as soon as she puts her foot down, it'll start to come back, unless we have done exercises for the external rotators. So at this point, I get some green TheraBand, and we start working on the external rotators abductors, which is predominantly glute max piriformis. So she goes out fast and in slow. Out fast, in slowly. Out fast, in slowly. And this biases the eccentric work, which helps in the recruitment phase of muscle. So that's the hip. Knee. What did you do to this knee?
Nothing. I know too much. That one's an ACL repair. I think from the breakdown long term of the car.
Okay. See, this one has what I would say is acceptable hyperextension. Pretty stable, a little bit of anterior jaw. But this one, I can't get this off the bed. So if I was looking at a dysfunctional knee, it'd be this one. But I see it's peppered with scars.
Falls as kids on it.
Yeah.
Mountain biking maybe.
You're supposed to stay on the bike.
I try. Sometimes it bucks you off.
Okay, so that would need treating. The treatment itself is pretty easy. The mobilization, don't let me lift your heel off the bed. and let go. So I'm focusing in on the resisting popliteus. Hold and let go. So as she relaxes, I take up the hyperextension slack and the external rotation. Hold, let go.
Oh, this is my side that has the syndesmosis on it from the rollerblading. So it could have occurred with the rollerblading when I stopped.